Good evening, everyone. Thank you so much for joining this event. My name is Rebecca Fitzgerald. I'm Professor of Cancer Prevention and a gastroenterologist, and I work at Cambridge University Hospitals and in the university doing research. We're very pleased to be hosting this webinar for you today. This is enabled by Heartburn Cancer UK, our fantastic charity who care for patients with heartburn and Barrett's esophagus. So would like to thank HC UK, Jess and her colleagues very much for enabling this today. So we've got what I think will be a great program. We're recording this as well so that you can refer to this later and people who can't attend live can dial in due course. So the agenda is to start off by discussing proton pump inhibitors, the pros and cons, a patient Google-based assessment. Then we're going to go on to a Barrett's registry discussion, what we've learned from 20 years of our clinical research. And then we're going to go into a panel session. And at the start of that, we're actually going to report to you the results of a patient survey and hear particularly from our dietitian and clinical research nurse about what we've learned from this survey before we open it up to a wider discussion. You can post your questions anytime in the Q&A, and we will get to them after each talk and also in the panel at the end. We'll try and answer all the questions, but sorry if we don't manage yours for some reason, and if necessary, we'll follow up afterwards and answer your question. So let's start then with hearing about PPIs. And I'm just going to introduce Dr. Oliver Stovin. So Oliver has been a rural GP for 27 years. He retired fairly recently, but he didn't really retire. He became a part-time Macmillan GP and cancer lead for Cambridgeshire. And his job was to improve cancer care across the whole of Cambridgeshire. He's been very involved with Barrett's esophagus Delta trial, which was a trial about the capsule sponge, giving us advice from a GP perspective. He's now completely retired, he says, and is a trustee for Heartburn Cancer UK. And he comes with two hats on tonight, really, because Oliver is also a patient with Barrett's himself. So he also speaks from experience. Just a bit more about Oliver. He's busy with grandchildren, keeping fit recently, and this is news to me, but I'm very impressed. He completed the London Classics, which involves the London Marathon, the Ride to London, and the Swim Serpentine. So you sound very fit. So over to you, Oliver, to tell us what you know about proton pump inhibitors from a GP perspective and also, I guess, as a patient. Thank you very much.
Thanks. So, I mean, I've just titled this, Should I Take Omeprazole Long Term? So it reflects that I did a bit of research basically with Google for my own interest to find out the pros and cons of PPIs. And the trouble is that I found the more I looked, the more confused I became. So I'm going to start with why take them in the first place. And definitely over the years, they've proved they're very good at reducing acid and treating my reflux. They're currently recommended in almost every international guideline for Barrett's to reduce progression. However, when I started looking, and there may be some dissent from Rebecca and others, but I couldn't find any real good evidence for their benefit and also how to quantify their benefit. But also when I was looking to see whether there was any difference between PPIs, there didn't seem to be anything either. When you look at theoretically, then I think, well, the PPIs reduce inflammation, and inflammation is definitely part of a cancer risk. So theoretically, they should be working. The other thing when I started looking was that I was well aware that not all the studies were great. And I'm not a statistician, and I've certainly out of practice of doing critical appraisals of studies. And the last time I did it was probably 45 years ago as an undergraduate. I found that my research was mainly influenced by the date of the article I was reading and the institution that did it. And I looked at reviews and original studies and certainly found a lot of newspaper headlines that I thought were incredibly biased. So I also tried to reflect on what makes a good study. And I think to put it into context, I looked at smoking, and I noticed in the 30s and 40s, there were some very good observational studies which showed that when they looked at people with lung cancer, most of them were smokers compared to people with other cancers. But it wasn't until 1951 when Richard Dole did a really good study where he recruited 40,000 doctors and followed them for 50 years in the end. And 87% of them smoked. But by 1956, so 6 years into the study, 750 of them had already got lung cancer. And he was able to quantify it and suggested that 25 cigarettes a day increased your risk of lung cancer 50-fold, and also found the link to heart disease. And even with this study, it was probably another 10 years before it was shown that most doctors accepted the link, and well into the 60s, still 50% of doctors smoked. I've been told that to repeat this study would cost anything between sort of 10 and 20 million pounds. So it's not the sort of really good study that would be done nowadays on many things, and particularly reflux. It's also interesting that he was one of the first people to harness giving his results to the public, and realized it had a much better impact than just informing the profession. I was then thinking about, what makes a bad study? And one of my friends came up with an example for an observational study, which suggested that if you read the Times, you will probably live longer than if you read the Daily Star. And obviously that's nothing to do with reading the paper, but it's a reflection of the different socio-economic status of patients. And we know that it has a dramatic impact on their life expectancy because of smoking, diabetes, diet, obesity, etc. And in this country, you live 10 years longer if you live in Kensington than you do if you live in Glasgow. If you actually were able to match everyone for all of their different risk factors, then I'm sure you'd find that reading whichever paper made absolutely no difference. So you can come to conclusions that aren't really true. So progressing then, I looked at all the negative things that have been written about PPIs, and noticed the ones that interested me most were cancer, Alzheimer's, infections, fractures, and low magnesium. Although I'm well aware there are lots of others, so kidney disease, B12. So for cancer, it was quite easy to find that PPIs affect gastrin levels and H. pylori levels, and these are both risks for gastric cancer. And some of the good reviews certainly suggested that there was a doubling of risk for long-term use of PPIs. Without the fact that I couldn't actually particularly quantify the risk from the benefit of PPIs in esophageal cancer, I certainly took the view that maybe they cancelled each other's out, but also taking into consideration that the number of esophageal cancers reported is 9,300, and gastric cancers are only 6,500. So my risk is far greater probably for the esophageal cancer. The only other thing that I gleaned was the idea that you could test for H. pylori before you start PPIs in order to decide whether your risk in respect of gastric cancer is greater. For Alzheimer's, again, I looked, and the theoretical things included things like feeding PPIs to mice, and they developed amyloid plaques in the brain, which have been linked to dementia. B12 deficiency has also been linked to reduced cognitive function. And then looked at a couple of good studies, and one that really hit the press not that long ago was a Danish study that followed a lot of patients and certainly concluded that dementia was a problem. However, they admitted that there were lots of compounding factors that meant that their results weren't reliable and it warranted further studies. But there was also another good American study that looked at whether aspirin was of a benefit to dementia. And in the same study, they looked at people on PPIs and found no link with dementia. But interestingly, did comment that when they looked at the two groups, the people taking PPIs and the people not taking PPIs, they weren't a very similar group, and therefore there were lots of compounding factors that might affect the evidence. So there were lots of good reviews of all the evidence, and most of them say that there's no statistical evidence highlighting a cause or link between PPIs and dementia. And there's currently nothing in the BNF, when I look it up, which is the sort of Bible for prescribing for doctors in this country. But I did notice that it's due an update in November 24. So I'm hoping that that will not change. When it comes to infections, we know that acid in the stomach kills bugs. And the two infections that people worry about are Clostridium difficile and community-acquired pneumonia. So C. diff is a gut infection that can cause severe diarrhea and significant problems. It's very nasty, mainly comes in entirely after antibiotics. So people should be aware when they're taking antibiotics that it's a risk, and if treated early, shouldn't actually develop into anything terrible. The pneumonia is because people aspirate stomach contents into their lungs. Again, it's worse for people who have at high risk of lung problems, and they should be aware of that and can act accordingly. But also there was a big study in Nottingham in 2016, which actually suggests there was no increased risk. Fractures, again, there's theoretical evidence, low acid levels in the stomach reduce the effective absorption of calcium. I think most sources seem to think that this is proven, but studies tend to be observational. And one of the good reviews suggested about a 36% increased risk. So I think one of the things that came out was the sensible suggestion that you should assess everyone's risk of osteoporosis and consider whether they should have PPIs or preventative medicines accordingly. And certainly there is a very good risk calculator on the UK Royal Osteoporosis Society. So everyone should be able to access that and calculate their own risk if needed. There's also low magnesium, which was relevant to me and can cause heart problems and fits. This again seems to be proven. Some of the studies suggested that there was about a 20% risk of developing low magnesiums, and it's fairly straightforward for doctors to measure it and act accordingly. So after all my research, I mean, my conclusions were, for me personally, that PPIs treat my symptoms, and I've been taking them for roughly 20 years. I've tried reducing the dose without success. I get my magnesium done every few years as it was low, and I take supplements. I've done nothing specific about osteoporosis and dementia, but I take vitamin D in winter and obviously plenty of load-bearing exercise. I'm aware of the infections. I actually also have a thing called bronchiectasis, which means I'm at risk of lung infections. So I actually have antibiotics in reserve, but I've only ever taken them once in 20 years. And the cancer, I think that not too worried that the risks counteract each other, but also when it comes to stomach cancers, I know I'm H. pylori negative. I've got no other risk factors. and for what it's worth, I'm blood group A, which is thought to have a lower incidence of stomach cancer as well, whereas blood group A is higher. So the bottom line is that the research I found difficult to interpret, and that I don't think I could answer most people's questions authoritatively. And the danger is that you believe what you want to believe. A good example being that I was actually iron deficient anemic 5 years ago and fully investigated, and no cause was found. But when I was doing my research, it suggested that PPIs can cause iron deficiency. But when I looked into it, because I was quite happy that I'd found a cause, it turned out there were only 4 separate case reports in the literature, and therefore the evidence is fairly poor, but I've ended up quite happily believing it. So thanks, and that's a lightning tour of my research.
Thank you very much, Oliver. So I think if I can give an even more brief summary, proton pump inhibitors are generally very effective at controlling symptoms, not in everybody, but in most people. And really, they're pretty safe. And these are some of the most commonly prescribed drugs actually in the UK and worldwide. They're incredibly commonly prescribed. So we have a huge amount of data. So some of those big studies now that combine, we call them meta-analyses, where they combine lots of different studies and try and really estimate risks and benefits, are pretty solid. And I think the gastric cancer worry, which was worry initially, I think most of us have felt reassured that that really isn't an issue. So I think in the interest of time, I'm going to go straight on, but I would encourage you to please put your questions in the Q&A. I don't know if you can see the little Q&A button, which should be at the bottom of your screen, because we will have time at the end. And thank you again, Oliver, for sharing that, both from your personal perspective as well as a GP. It always speaks much more, much more impactful when we think about it from a patient point of view, as well as just as doctors, what we prescribe. So that's really helpful. I'd like to introduce my colleague now, Dr. Massimiliano di Pietro. So Massi hails from Naples, but he's been in Cambridge now really for quite a long time, since about 2007. Don't know if he would count himself quite a Brit yet. I think once an Italian, always an Italian, but he's certainly very well known to many of you on the call, I'm sure, and our Cambridge team. So Massi is an expert in Barrett's, both diagnosis and treatment. He's also been advisor to the National Institute of Clinical Excellence, NICE, about the updated guidance on Barrett's esophagus. And he's going to tell us something which you may not be so familiar with. Many of you in the Cambridge area would have consented to our Barrett's registry, but this is really a goldmine of information for us. So we're very grateful for all of you that have joined in this effort. And he's going to tell us the Cambridge Barrett's registry, what we've learned from 20 years of clinical research. Thank you very much, Massi.
Thank you very much, Rebecca, and good evening, everyone. It's really a pleasure to be here, and an honor to actually share with you the results of our Cambridge Barrett's registry. And as Rebecca mentioned, I think it's important that the results of the research are shared with the primary participants of the research. And I think this is a great opportunity to actually let you know what we found after nearly or more than 2 decades of research. This is by no means my own work. I have done my bit, but we've had a lot of people from Cambridge, many of whom you might actually spot in the list of people here. But for example, Judith and Keith are gastroenterology fellows that have worked with us over the past few years. And then there is a list of medical students that have given a great contribution to our research, as well as established doctors. We have quite a number of people in our research team, and I've mentioned the endoscopy fellows, but I would like to acknowledge the incredible work done by the research nurses that have kept the contact with you and cared for our patients for so many years. as well as administrators that book appointments for patients and data managers that look after the data. So it's really a large group of people that have enabled this research. And just to mention our database where we enter the data, this is an anonymized database. So immediately after the consent, the data of the patients is anonymized. It means that name and date of birth are eliminated. Patients are assigned a research ID. And this tool really is an important tool because also enables people that are not member of the clinical team to actually look at the results, which are really important for a number of experiments that we do in the laboratory. I just want to mention for those of you who are not familiar about why we monitor Barrett's and what happens in some patients during the course of the monitoring, that obviously the transition from Barrett's to cancer, and we'll be talking about how often this occurs, does not happen all of a sudden. It does go through steps. And these steps are what we call dysplasia. Dysplasia is, in other words, a precancerous change of the cells of the lining of the esophagus, which can be graded on the biopsies and is graded as low-grade or high-grade dysplasia, depending on how closer to cancer it is. So low-grade dysplasia is a minor change. High-grade dysplasia is a more severe change, which resembles a little bit more closely the cancer, and does increase the risk for cancer to happen. And even cancer can be, how we say in medicine, staged. The objective of the surveillance is to try and diagnose the cancer very early. So at the stage that we call stage 1, and in particular, the stage T1A. I mentioned this because you will see this acronym later on. T1A is a cancer which is fully curable with endoscopic treatment. So even if it happens, it can be successfully cured with the endoscopic treatment. And this is really what we want to diagnose if there is a progression to cancer in some of the patients. Obviously, inevitably, some patients might progress to later stages of cancer, but this is supposed to happen very seldom in people which are monitored for Barrett's esophagus. And the type of cancer which is linked to Barrett's esophagus is called adenocarcinoma. So the questions that we try to ask ourselves and to find an answer through these 25 years of experience are listed here. And really, we ask ourselves how often actually dysplasia or cancer are diagnosed in people with Barrett's esophagus. And in particular, we use our research to try and answer this in our particular group of patients. We also ask ourselves what are the risk factors for dysplasia and cancer. We also wanted to look at something that might be difficult to talk about, but some people, unfortunately, with Barrett's might develop cancer and might die of this cancer. And we really wanted to understand how common is this in our practice. And finally, we wanted to look at how effective are the treatments that we use to resolve the dysplasia and the cancer, and how they can help preventing further problems down the line. So with the help of our database and with the help of medical students that look at medical records, we collected data from as back as 1997, all the way down to the most recent years. And that flowchart that you see on the right just says how many patients we have looked, and we started off with nearly 2,000 patients. In research, we often have something that we call inclusion and exclusion criteria. It means that some people are sort of eligible to be looked at based on their records, some other are not. And eventually, after applying these exclusion criteria, we ended up with a group of 969 patients, which are those that are eligible to provide the answers to the questions that we ask ourselves. And nearly 1 in 10, so nearly 10%, actually just over 10% of these people, during the course of their follow-up, developed dysplasia or cancer, in particular high-grade dysplasia or cancer. And quite reassuringly, I put here the breakdown of the different stages of dysplasia or cancer. So the majority of these people that progressed to later stages only progressed to high-grade dysplasia or T1A cancer, which, as I mentioned before, are stages of the disease which are fully curable with the endoscopic treatment. And very, very few progressed to cancer stage higher than T1A, which is the type of cancer that often requires chemotherapy or surgery and poses a risk to the life. So that was actually quite reassuring for us. We also looked at how often this progression occurs in Cambridge in comparison with other studies that did similar type of analysis. And we've listed here 4 different studies from different countries, and I would like to point your attention to the yearly rate of progression. So it might be a bit counterintuitive, but in Cambridge, we had a higher rate of progression, which is more patients progressed to high-grade dysplasia or early cancer compared to other studies. And it might be worrying to you, but in fact, it's quite reassuring for us. And that means that we were able to diagnose the earlier stages of this progression more often and apply adequate treatment. And that yearly rate of 1.63 just translated into more friendly numbers means 1 patient every 60 per year. So obviously this is not full-blown cancer, this is just high-grade or even early cancer. So that means that we were effectively able to diagnose these stages quite early on. The second question was about the risk factors. So we looked at the different risk factors which have been somehow described in the medical literature. And those that have a number next to it are those that in the statistical analysis were correlated to the progression. It was not surprising that with age, people are more likely to develop the dysplasia or cancer. It was also not surprising that some factors like alcohol were associated to the progression. It was interesting for us to see that smoking was not. However, we cannot be fully conclusive on these because there were some missing data in our study. So I wouldn't recommend to smoke. I think avoiding smoking is still an important quality measure to, a lifestyle measure to reduce the risk of other problems. Also the length of Barrett, so the longer is the Barrett's, we generally measure it in centimeters, the higher was the risk, and also people with low-grade dysplasia, so the earlier stage of dysplasia, were at higher risk. So how common is dying of cancer? Well, we found that among those that develop cancer in our group of patients, 8% died of their cancer. We included all patients. We included in our study even patients that during the course of the study declined further surveillance. And in fact, some of them, unfortunately, are among those that had more advanced cancer. Or we had some people that when they developed cancer, unfortunately, they were not fit for curative treatment. And if we compare this rate with what is written in the medical literature, we were quite reassured by the fact that in our cohort, the percentage of people on surveillance that died of cancer was lower than any other study which is published in the literature, where that rate is between 17 and 50%. So I think, to me, this speaks very highly about the quality of the service that we use and how effectively we are able to prevent more significant problems. So, and finally, we asked ourselves, how effective are the endoscopic treatments that we apply for Barrett's esophagus? Now, we included in this analysis also a lot of people that were referred to our center by our district hospital in the region. We included here people that either had an endoscopic resection to remove maybe a nodule or a little area of cancerous change, or radiofrequency ablation, which many of you will be familiar with, is the endoscopic treatment to ablate, to eradicate the Barrett's esophagus. Well, the majority of the patients achieved complete response to the treatment. And this DSM is an acronym, and sorry, I should have removed it, which stands for disease-specific mortality, which means that people that have died of cancer within this group of people treated. And only 5 patients were unlikely to, unfortunately, die of cancer among these nearly 300 people that were referred to us with either high-grade dysplasia or an early cancer. So this again suggests that the endoscopic treatments that we applied were very effective and really prevented progression in the majority of people. Some people had recurrence, so the dysplasia came back, but in the majority of them, we were able to treat them successfully. And the risk of complications was actually very low from the endoscopic treatment. And the majority of these complications, except one patient that required surgery from an endoscopic resection, were successfully treated endoscopically. So in conclusion, I think we can say from this data that the Cambridge endoscopists, part of the Cambridge research team, are actually very skilled in making diagnosis of precancerous and early cancerous lesions in Barrett's esophagus. We found that age, the size of Barrett's, and the low-grade dysplasia are the strongest factors that correlate with cancer. We were very pleased to see that Cambridge has one of the lowest cancer-related mortality among the patients that are looked after by our team. We also proved that in our hands, the endoscopic treatments were very effective. So I was very pleased and proud to see the results, and I'm very happy to share them with you. And this is hopefully going to be published in a medical journal very soon.
Thank you very much, Massi. Very encouraging indeed. Can I just ask you to clarify one of your statistics? Because the 8% risk of dying perhaps sounded a bit alarming, but that's 8% of those with cancer. So the overall percent is very low.
0.4%, in fact.
Thank you. Yeah. So I think that's good for people to know.
Yes.
Yeah. And similarly, the adjustment has to be made for the overall rates for other centres of 17 to 50%, because otherwise that sounds huge. So really, really low risks. So that's fantastic. Any questions? So yes, thanks for your presentation and the hard work. Will it be possible to access the recording? Yes, we'll send that to all attendees afterwards. And there were several other questions around PPIs, which I've answered in the chat. So hopefully you've seen those answers. One of the ones which is a particularly interesting question is, if you don't have any symptoms, should you take proton pump inhibitors? It might be interesting to hear Massi's view on this, but Generally, I think NICE now recommend, the National Institute of Clinical Excellence do recommend taking proton pump inhibitors if you've got Barrett's esophagus, but you should, always weigh the benefits and the harms. So one big trial that Oliver didn't talk about was something called the ASPECT trial, which was designed to see if proton pump inhibitors or aspirin could reduce mortality from esophageal cancer. Everyone had a proton pump inhibitor, so it's a little bit difficult to draw very definitive conclusions, but people had either a high or a low dose. But overall, that study showed that while aspirin didn't really make any difference, the proton pump inhibitors may make a difference. So I think that's why we generally think it's worth taking it. But on a case-by-case basis, if you're getting side effects from those medications and you don't have symptoms of the reflux, then probably don't take them, would be my view. But I don't know if Massi wants to comment.
Yes, so I agree. So there is a lot of what we call retrospective studies looking back in time that showed PPI to be protective against cancer. The only prospective study did not show, but because all of them were on PPI, as you said. In general, we always recommend to find the minimal effective dose, so the minimal dose of PPI that control the symptoms, which is obviously important for quality of life. And we really think that minimizing the level of inflammation in the Barrett's can help preventing. Although, as unfortunately you said, the highest quality of evidence, which would be a study where people are either given or not given the PPI, would be unethical, because otherwise we would have 50% or nearly 50% of people exposed to the symptoms of reflux, which would be quite hard for patients. Oliver, I think you had...
Thanks, Massi. Oliver, did you want to make a further comment?
Yeah, I've just made a comment about that, in the sense that I know I've had about 5 or 6 gastroscopies over the years, and what they find in respect of the amount of esophagitis I have often bears no relationship to my symptoms at that time. So I've never thought that my degree of reflux has actually matched what's going on in my esophagus, or my degree of symptoms. And therefore, one of my reasons is thinking that I am reducing my inflammation while I'm taking them. And so
Thanks.
even without symptoms, I might be taking them.
Thank you, Oliver. Good. So good to have some discussion going. So I'm going to move on now to the results of our patient survey. And I'm going to introduce Claire and Irene to you. So Irene is a principal research nurse who's worked with me for 18 years, gosh, for particularly around our studies with the capsule sponge, previously called cytosponge, that many of you have kindly also taken part in. And she's our expert trainer for capsule sponge, but also an expert in Barrett's herself. Also I want to introduce Claire Lamb, who is one of our upper GI dietitians at Adam Brooks Hospital. She's a graduate from Nottingham University. She's got a master's in human nutrition and dietetics, and she works particularly with our cancer patients, but is also an expert in upper GI more generally. And so it's really helpful, Claire, to have your input for this webinar. So I think you and Irene are going to take us through the survey, what people said and what your thoughts are around those queries, and then I'm going to open it up to a broader discussion. So please take it away. If you can put your slides on presentation mode, that would be even better. You're on mute, Irene.
Take that off. Thank you very much, Rebecca, for that lovely introduction. But also just to say to the patients who took part in the survey, a very big thank you to you for answering the questions and really helping us to assimilate the questions and the answers, which helped to put together this patient survey. We ran the survey where we asked several questions. I think there was 15 in total, about diet and lifestyle, symptom control, and risk for the risk factors for esophageal cancer. And out of those questions, we pulled out a few that had various answers, and really to Claire's going to expand on that for us from a dietitian point of view. So I will. So Claire, I think this question was, if you suffer from indigestion or heartburn, what diet tips can you follow to help relieve these symptoms? And we had, as you can see on the bar chart on the side, the starred answers are the correct ones. So eating small regular meals, chewing gum, controlling the amount of alcohol you drink. We were quite interested in why does chewing gum help, Claire?
I mean, while Claire's answering, can you try and put your slides to full screen, because they're very small on the bar chart stuff, and then people will be able to see. But don't worry too much. If you try and change your presenter view, probably on your display settings. Claire, go ahead.
Yeah, thank you, Irene. It was actually very interesting to read the responses to all the questions, and I think I don't know if a lot of you, we've done a talk before, and I think definitely some people have listened or done their own research. And yeah, I will expand on the chewing gum question, but I think a lot of people are obviously doing a lot of the things that we would be recommending, which is wonderful. So small and regular meals, 97% of people chose that, which is great. A few glasses of red wine every day. That's interesting. So I think that's 2.7%, but also controlling the amount of alcohol you drink, 50% of people found that was beneficial. So I guess it's, as you've all probably been told, it is very individual, and there are a lot of things that will work for some people and things that unfortunately won't work for other people. But a lot of the overarching principles most of you have chosen. But in terms of chewing gum, so actually chewing gum promotes saliva production, and actually that can help to neutralize stomach acid. And there is quite good studies surrounding that, and I think that the current guidelines are about 30 minutes after a meal is chewing sugar-free. I will emphasize chewing gum can be quite helpful. So yeah, that's really the answer to that one in terms of a chewing gum. There's sort of extra questions at the end, so if anyone wants me to expand on any of the other responses, I definitely can do, but I'll let Irene go through the slides first, and then we can come back if there's additional questions.
Great, thank you, Claire. We also asked, does ginger help with heartburn or indigestion? Have you had questions regarding ginger?
We have. Unfortunately, the evidence is not spectacular, as with a lot of these things, and it's very difficult. We touched on at the beginning that a lot of studies, in order to do controlled studies, so without a lot of the other influencing factors, is particularly difficult. And putting someone on a ginger-only diet is not something that we're able to do, so that can be quite challenging. So there was quite a big meta-analysis study done in 2022. And there was some suggestion that the 4 grams of daily ginger can be helpful, but more in terms of, as you've listed in one of the answers, in reducing inflammation. So reflux can cause inflammation. It causes inflammation of the esophagus. That's what causes a lot of the pain. So rather than actually stopping the actual reflux itself, it can help in some of the symptoms by reducing the inflammation. If that makes sense. But it seems to be that 4 grams is the sort of helpful dose. So yes, again, slightly anecdotal evidence. So I suspect that's why we've maybe had sort of the 50% and the 41%. About half of people have obviously found that helpful, and half of people have not necessarily found it helpful. So yeah, that would be my answer to that question.
And in your experience, Claire, what are the helpful remedies could people use to help with their heartburn?
Yeah, so again, in terms of anecdotal evidence, we've heard lots of things, but the overarching principles would be that sort of the little and often smaller, more balanced meals. There's some evidence to suggest higher fiber meals are better. Avoiding kind of eating and running. So we always say giving gravity a chance to help to move things through, rather than getting up and moving around. Avoiding sort of bending over and moving around too much, or having more sort of lifestyle, I guess, than diet, but having clothing that's too tight and kind of pushing the stomach, pushing things up. In terms of alcohol, so alcohol is a relaxant, so it relaxes a lot of the muscles in the esophagus and the valves that stop the stomach acid coming back up. So that's where alcohol plays a part in that side of things. There are some foods that might relax the muscles as well. So again, that's sort of the thinking behind that. Smoking is similar, so that can increase. Obviously, Massie's already touched on that. Taking time and avoiding stress, which I know is not possible, but as well as diet, the lifestyle type factors, stress can increase reflux. So again, if you're making everything stressed and tight, that can push things up in the wrong way. Yeah, hopefully that covers a little bit of that. I think actually one of the next questions might answer it a little bit more. Am I right in thinking there's another?
Sure. I'll move on to the next one.
The next,
yeah.
And again, answer some of that. So
yeah.
Again, I suspect a lot of anecdotal evidence. You know, so again, some people have chosen helpful things. So tomato-based products increasing heartburn, only certain types of fruits and vegetables causing heartburn, citrus fruits, onions, and garlics are likely to make my heartburn symptoms worse. So I would say, you know, more than 50% of people have chosen those things. So tomato-based products wise, that is quite related to the fact that tomatoes are acidic foods. So they kind of, you know, increase the acid in your stomach. Citrus fruits, again, are a bit more acidic. In terms of onions and garlic, so there's actually some thought that in terms of spicy foods and some of the sort of the makeup of onion and garlic actually contain things that, again, can relax the muscles. So that's thinking behind some of those products, foods making that worse. So, and also products that are high in what we call fermentable carbohydrates can kind of increase the gases in the gut, but in the stomach, and just generally make things a little bit more difficult to go the right way and just causing a bit more bloating. And again, I think in terms of certain types of fruits and vegetables, I would say a lot of that is individualized on the patient. Again, doing a controlled study of those things is quite challenging. But it is kind of the tomatoes, the garlic, onion are the main things that we tend to hear about. Other fruits and vegetables better, but it can be very individual as to how you digest and process those foods as well. General sort of gut health and bowel health are really important. So, you know, not getting constipated, not having other things that are going to put that pressure and bring things up the wrong way. And again, that's individual to everyone in terms of how much fiber in your diet is important for that good bowel and gut health. So I think my best advice would be, you know, trying different things, but also being aware that because it isn't the same advice for everyone, what we don't want is people cutting out things that may not be necessary for them. So where some people might find tomato, even dairy we get quite a lot of, could cause problems. If it doesn't for you, then we don't want you cutting it out, because we want to be thinking about overall balanced diets. Does that help a little bit?
Yeah, and
Claire, that question.
That's brilliant. Claire, something I've been thinking about is probiotics, things like, you know, your Yakult and things. Is that good for your stomach?
Yeah, so we get quite a lot of questions about sort of pro or prebiotics and general gut health and what we call gut microbiome. And I think that gets touched on a little bit with PPIs as well, and general gut health. They are helpful. It doesn't necessarily, in everyone, again, reduce the risk or the amount of reflux, but it is certainly helpful. Thinking about studies in terms of pro and prebiotics, unfortunately, it seems to be something I say all the time, but the evidence is skeptical, particularly with probiotics. So I'm sure that a lot of you have looked into them. but there are literally millions of strains of probiotics, and they are in many different forms. So they can be in tablet form. They're live in terms of the Yakults, yogurts. So it's really difficult for us to identify which strains are helpful in exactly which things, and also how much of those things. So again, it's something that I would say you could trial, and it may be helpful for you. They may be more helpful in people who are, for example, having to take things that, like antibiotics, that we know do affect your gut microbiome. Yeah, I would say try them. It's thinking about trying them for a consistent length of time, and also the doses can be different depending on which product. So things like Yakults actually, I think, works in 3 or 4 a day. So it's, you have 2 drinks, but you also need to be buying their butter products, their cheese products, all of those things. So it's also the cost of those adds up. The tablet form as well can be very expensive. So definitely scope for trying, and then making sure if you're trying those things, you're not trying that at the same time as you're doing lots of other things, because you won't know which thing is beneficial.
Yeah.
Yeah, that would be my. And it's something that hopefully we'll get more and more information about probiotics, because I believe they will be helpful, but it's just getting that exact evidence to make it possible. Yeah.
And for somebody who's experienced quite a lot of symptoms with different foods, would a food diary be an effective way of tracking that?
Yeah, definitely. So obviously not everyone has access to a dietitian necessarily, but doing what we call a food and symptom diary for at least a week is a really helpful way for you to identify potential triggers. So every meal, how you're feeling after that, and it's thinking about looking not just over a 24-hour period, but into the next day as well. Could it be something I've had the day before? And as I briefly mentioned, you're keeping an eye on your bowel habits as well, because those could be things that are influencing that. Actually, if you're not opening your bowels for 3 or 4 days, is it that the constipation is impacting it? So yeah, a full kind of food and symptom, including bowels, is really helpful for you to be able to spot some of those things.
Great, thank you, Claire. I think Rebecca, you might be able to see the Q&A.
There are some more questions for you, Claire.
Yeah.
So how do you take ginger?
Yeah, so literally orally. So you can make things like ginger tea, but you're not getting the full. If you've measured out your 4 grams for the day, and you're taking it in something like tea, you're not getting the full benefit of the ginger. So you can make it in teas or actually cooking with it. So it could be in things like stir fries, curries. But yes, actually sort of consuming the actual ginger as well itself, rather than just in a drink, seems to be what was coming out of the studies.
So is stem ginger or crystallized ginger all right, where you've got sugar on the outside? That might make it easier to eat than a bit of root ginger. I'm just
yes. Again, it would be slightly, if you're someone that kind of sugary foods and rich foods make your reflux worse, then maybe avoid the whole 4 grams as crystallized ginger. But if you're someone that doesn't seem to make a difference to your reflux, then absolutely you could try that. But the sort of fresh stem ginger is probably the best way. But as I said, that study was vague enough that unless you're someone who quite likes ginger, I wouldn't suggest going fully into the ginger diet.
And is a fasting diet beneficial?
So that's probably a question I don't have the answer to. I think the fasting diet can be difficult depending on the timings that you're fasting. So often it's kind of, you break the fast in the morning with maybe a smaller meal, and then you've got quite a long period during the day and tend to have a bigger meal at night. So I would be thinking about things like the volume of meal and how close you're having it to going to bed or sitting idle, not doing things. So not necessarily the types of food in that type of diet, but the timings of meals. Would that increase your reflux? I can't imagine it improving it because I don't see what benefit in terms of reflux that would have. I guess in terms of a lot of the fasting type diets, they're based often on sort of slightly higher fiber foods, healthier foods. There wouldn't be as many energy dense rich foods if you're following a strict one of those sort of fasting diets that are out there. So the types of foods may be better, for your reflux, but that lifestyle and habit wouldn't, I don't think, have a significant impact. Hopefully that's helpful.
Thank you, Claire. I always find it so helpful hearing your tips. And it was lovely hearing a conversation between you and Irene. That was a great, and the results of the survey. It was really informative. So thank you so much for joining the webinar. We really appreciate it. So we're going to move now to some more general
Thank you,
questions.
Claire.
And I'd just like to introduce another colleague, Dr. Andreas Hadjinicolaou. I always worry about pronouncing Andreas's wonderful name correctly, but he's trained in some of the best places, Cambridge, and then he did go to the other place, Oxford, for a while, but I think that's quite a good place too. He's also spent a bit of time at Stanford and at London, and he has got a special interest in upper GI diseases and Barrett's esophagus in particular, and he's doing some research with us as well at the moment, as well as joining Massi often in the endoscopy room. So many of you in Cambridge will be getting to know Andreas. And so he's going to join us for some of the more general questions for the last few minutes. So myself and I see Massi and Oliver, we've been answering quite a few of the questions as we've gone along. So hopefully those answers are helpful. Perhaps a few of the interesting questions that we might want to just open up to the group a little bit more. So one of the questions was about genomics and how that will impact on current patients. So I should, I guess, explain what we mean by genomics. So we're meaning genetic tests, not in terms of hereditary genetics, but in terms of looking at the tissue for not just the cell changes that we looked at down the microscope with the traditional pathology, but also looking at changes in the genes, in the tissues, that mutations occur, especially inflamed tissues and over time. And what can we learn about those for Barrett's risk of progression? Could that give us more clues about who's at risk of progressing and help us, predict risk better? So do you think this is something that's going to be something more in the future? I mentioned in my written answer that I think we're starting to do this with one of the genes called P53, but I wonder what, Andreas, you think?
Yeah, so I think the more we understand about the disease and the natural progression, the more we can get closer to what's called personalized treatment. And I think genomics will be a huge player in that. And this is what we see not just in the esophageal arena, but in most cancers and most premalignant lesions, where we're trying to identify the genetic changes that might give an answer not just to diagnosing the disease early, but also identifying therapeutic targets for the disease as well. So I certainly see genomics playing a larger role as we move towards a personalized medicine approach.
Thank you. Massi, do you have anything to add to that? I mean, do you think it's feasible to start doing these genomic tests? Do you think it's going to become more routine because it's quite specialist, I guess? So, is it getting affordable and feasible technically, sort of in a practical sense, even if it's very useful?
Yeah, I mean, it's been very interesting to see how the cost of the some of the technologies have come down in the last few years. Before, sequencing a genome looked like a mountain to climb, but now it's becoming more cost effective. And obviously, I think we were still not there in terms of having a genetic test, but we have come recently back from a conference, and I think there is more and more data to support that we are not very far from having some tests that can inform practice on top of the standard tests like an endoscopy and the results of the biopsies.
Thank you, Massi. And then I wanted to turn to a question which is very sort of dear to my heart. So the question is, should those with long-term heartburn always be tested for Barrett's? Oliver, what do you think?
I was just typing an answer. So I think yes, because what I was pointing out was that as far as the figure I quote is that less than 20% of people with Barrett's have been diagnosed. So I don't know whether you agree with that figure, but therefore there's an enormous pool of people who are at risk of developing dysplasia and progressing that we don't know about. Mine is that the capsule sponge would appear to be the ideal way of increasing the diagnosis, and it has to be assessed, which we do, or you're doing with best 4, hopefully, and then it can be rolled out in a way that the country and the NHS can cope with and afford.
Yes, so that's, I mean, for big nationalised screening programmes, like for colon cancer, we have FIT, or for breast cancer, we have mammography. Obviously, you need a very high level of evidence to really show that the benefits outweigh the risks and that it's feasible and affordable. But I think in the meantime, what we can do is when people go and see their GP, well, first of all, we should encourage people to see their GP with heartburn, because a lot of people, because you can get the tablet so easily over the counter, you think, well, why bother seeing anyone? I don't need to see a GP. So if we can get people to take it seriously and realise that they should see somebody, then if the GP knows that there are simple tests available like capsule sponge, then they can do that without necessarily having to refer for an endoscopy, and that should be more cost effective for the health service. And that is something which is now in the national guidance, in the European Society guidance, I should say, and the American College guidance. So increasingly, GPs do have access to capsule sponge as well as to endoscopy if they want to refer people. But we do need to get the awareness out there, because most people just ignore their heartburn. And whatever tests we have available, of course, unless people go and seek help, then we can't make any difference. Andreas or Massi, do you want to come in at all?
Yeah, so I think, statistically, we know that approximately, 1 in 10 patients maybe with gastroesophageal reflux disease will go on to develop Barrett's esophagus, and we think that Barrett's esophagus itself is probably underdiagnosed already. Reflux disease is also the most closely linked risk factors to esophageal adenocarcinoma, which is the cancer we worry about in the context of Barrett's itself. So based on those and the really good techniques that we currently have, not only to surveil Barrett's, but to identify any changes early and treat them, I think it's definitely worth considering, including certain other risk factors on a patient-by-patient basis, whether to proceed with further investigations in that context.
Do you think that the multi-cancer early detection tests are going to help? But if you're familiar with these tests, that people, there are several blood tests being developed, some of which are now available on NHS trials, and some you can get privately to go and get a blood test to see if you've got cancer.
I think that's a tricky question at the moment. I think there is a chance to influence and improve the information gathering stage with those tests. I think there's also still the risks of many false positives and false negatives, given that most of these tests are still currently being investigated. And I'm not sure we know exactly what to do in those cases. I think there is a scope, again, in the future for those tests to potentially act as a triage tool, or as an adjunct to the rest of the investigations that we currently have.
Thank you, Andreas.
Are you talking about the gallery test?
Yes, amongst others. Yeah.
I thought I saw something recently that there was they were disputing some of the evidence for that as well, and it did worry me as well, because so the blood test tells you where that you've got a risk of cancer and where it is roughly. And if you're one who has a blood test that says that you've got esophageal cancer, then when they examine you, you've got about a 50-50 chance you have, but you don't know what it means if you haven't. If they can't find it and things, I think it's a long way off myself.
And the other thing is we know it can detect cancer, but it's not clear it can detect pre-cancer like Barrett's. So I think that's an important message.
A different beast.
So I think if you have heartburn, still I would say get your esophagus looked at in the first place. Yeah. There's another question, which is a very interesting one. Massi, I'm going to put this to you, if that's okay. Do you think that eventually it could be possible for genomic manipulation to prevent cancer? Or if I can add a rider to that, you know, or do you think it's currently we diagnose it, we find dysplasia, and then we treat at that point? Do you think that's going to be the way we'll keep going? Or do you think in the future we might prevent it from the beginning? And could that be some kind of genetic or other manipulation?
Yeah, I mean, that's a difficult question to answer. I think it is unlikely that we'll be going into genetic manipulation for sporadic cancer. What we are certainly, and then when sporadic, what I mean by sporadic is a cancer that is diagnosed in a person without a genetic mutation.
A hereditary genetic mutation.
Yes.
Yeah.
So I think we're certainly almost there in terms of, as Andreas was mentioning before, understanding the genetic setting of the cancer and tailoring the treatment. But in hereditary cancers, and this is not the case for Barrett's esophagus, I think there is some evidence that this could potentially be implemented in clinical practice to try and reconstitute and fix the gene that is broken in some people. So I think there's still decades probably for this to be applied to clinical practice, but I can see that genomic manipulation potentially happening in hereditary cancers.
And maybe there may be other preventative medicines that come along. But I think the thing is, in the meantime, we have such effective endoscopic therapy. And generally you always have to weigh up risks and benefits. And so the reason we don't treat all Barrett's with ablation therapy and just get rid of it is because we know that that does have some side effects, and that's why we reserve it for people with dysplasia. And the same thing, I guess, would apply for a medicine. If you had something that could prevent cancer, it would have to be incredibly well tolerated and very, very safe, because Barrett's overall is generally harmless. Most people with Barrett's will never get cancer. And I think that's maybe quite a good note to end on. And as Massi has said, you're in very, very good hands with expert services looking after Barrett's patients. So Irene, I don't know if you can stop sharing your screen so that I can just see the whole panel on full screen, and we can just, that will allow me to bring this to a close. To thank
Rebecca, could I just interrupt just 1 second? Sorry, I can just see there are 2 attendees, Claire and Christine, who have got their hands up. So I assume they want to ask a question. Could I ask them to put that in the Q&A? Or alternatively, if that's not possible, then do please feel free to email us at info@heartburncanceruk.org, and we'll try our very best to get your question answered. So thank you, Rebecca.
Yeah, sorry, this platform doesn't allow us to take verbal questions. You have to put them in the Q&A bottom at the little button at the bottom. So, but we will answer questions offline. Be very happy to do that, and we'll also share this webinar so that you can all play it back and listen at your leisure. So thank you all for attending. We really appreciate your interest. Please do share this webinar for anyone else you know who might be interested, and they can listen to the recording. And a great thanks to our panelists for taking up their time on a Thursday evening in the pouring rain, so maybe certainly here. So it's been a very worthwhile way to spend an evening. We always learn as much from you all as we do, you know, as you do from us. So it's very much a mutually shared experience. And as Massi said, we're hugely grateful to all of you who take part in our studies, capsule sponge studies, registry studies that enable us to learn much more about this condition and do better for you all. And thank you to Heartburn Cancer UK for the fantastic work you do as a charity to support patients and get the word out there. We're very grateful. So thank you everyone once again for joining, and take care. Thank you.
Bye everyone.
Bye-bye.
Bye-bye.